Thank you for the opportunity to present our work today. We have no financial interest to disclose. Cardiac implantable electronic devices, or CIEDs, are being utilized in an increasing number of patients worldwide. Within the US, 3 million patients have CIEDs in place, with 250,000 new devices being placed annually worldwide. Electromagnetic interference is interference of CIED function by environmental electrical activity. This EMI can damage the device or cause temporary dysfunction, both of which can permanently harm the patient. These CIED devices include pacemakers and implanted defibrillators, and both types of devices consist of a generator and one or more electrodes. Pacemakers provide electrical signals to the myocardium, triggering contraction of the atria or ventricles. Implanted defibrillators, on the other hand, detect irregular electrical activity, which initiates therapy to reverse these rhythms. In either setting, disruption of these therapies or initiation of inappropriate therapy can cause problems for a patient. This disruption can occur with electromagnetic interference, or EMI, due to the devices interpreting EMI as intrinsic cardiac activity. In the setting of pacemakers, this may cause the pacemaker to stop delivering therapy. When in the setting of ICDs, this could lead to the device delivering an unnecessary shock. EMI can occur with any monopolar electrocautery, including argon beam coagulation, as well as radiofrequency ablation. EMI is particularly a concern in endoscopic therapies due to the proximity of the energy delivered to the heart and the CIED. Limited data exists regarding EMI of CIEDs during endoscopy, with only a few case series currently published. The two largest series by Baig and colleagues and Chang and colleagues reported many cases of EMI during endoscopy, including several episodes of device program alteration or therapy disruption, but neither study reported episodes of patient harm. Several guidelines exist to help provide instruction on caring for patients needing endoscopy who have CIEDs. For example, the American Society of Gastrointestinal Endoscopy published guidelines in 2007 with an update in 2013, in which they recommend all patients with CIEDs undergo pre-procedural assessment of their device type and whether they are device dependent. The guidelines also recommend, in the setting of a pacemaker, that the device be reprogrammed if the endoscopist anticipates prolonged electrosurgical therapy. For ICDs, ASGE recommends tachyarrhythmia detection be deactivated for the duration of the procedure. So given this information, we aim to evaluate the frequency of EMI during endoscopy in patients with CIEDs, and we hypothesize that EMI of CIEDs can occur during endoscopic procedures and result in adverse outcomes. To answer this question, we use the FDA's Manufacturer and User Facility Device Experience Database, or the MAUDE Database. This database is a repository of medical device malfunctions, including certain mandatory reportable events. These reports are submitted by manufacturers or healthcare professionals and include data from as far back as 10 years prior. Here you can see an example report as it appears when downloaded from the FDA site, and it primarily consists of free text data. We do not show every column of information here, but categorization of these reports has been limited. We reviewed the MAUDE database for the purpose of the study for the last 10 years, querying for 7 problem codes related to our study, including EMI, defibrillation, and pacing problems. We then cross-referenced these reports with the following keywords: cautery, electrosurgery, electric, and Bovie. Only reports that involve endoscopy were subsequently included, and any duplications reports were excluded. Ultimately, we identified 311 reports of CIED dysfunction of the 43,759 reports that were pulled based on the product codes that we used. Of these 300 roughly reports, 45 cases involved endoscopic procedures. 26 of the 45 reports involved a patient injury, including 5 patients with bradycardia or asystolic events, 3 with CIED damage requiring explantation and replacement, 17 patients who received inappropriate shocks, and 1 patient who had an untreated ventricular tachycardic episode. Several other patients had EMI that impacted treatment but did not lead to injury. This includes 9 patients with asymptomatic bradycardia, 6 patients with oversensing without therapy delivery, and 4 patients who had program changes or damage to the device that did not require the device be replaced. A magnet is frequently placed to change the CIED settings in the setting of a procedure, and are common safety measures taken to prevent adverse events due to EMI. However, 13 of the 45 cases occurred despite the use of a magnet, with 7 of those resulting in injury. There was no difference in injury frequency in cases that involved a magnet versus those that did not, however. Now, concerningly, episodes of EMI appeared to increase over the length of study duration, with most recent years having the highest rate of recorded episodes. So to summarize, electrocautery during endoscopic procedures carries a risk of EMI with the possibility of adverse events in patients with CIEDs. The incidence of injury due to CIED dysfunction during endoscopic procedures remains very low. However, despite the rarity of these events, the incidence does appear to be increasing. And importantly, the usage of a magnet does not prevent these adverse events, and long-term device damage can occur due to EMI with CIEDs. To conclude, EMI during endoscopic procedures is, although rare, an adverse event that providers should be mindful of. Prospective studies are ultimately needed to determine what risk factors increase the likelihood of such events and what methods can be utilized to lessen the chance of such events. Thank you for your time and attention.